Hello, this is Ellie. I'm the Peer Support Coordinator for Action on Postpartum Psychosis, and we're here today. Thank you to Perinatal Mental Health Partnership for asking us to do this Facebook Live for Maternal Mental Health Week. It's really good to be with you all. And yeah, I'll let the others introduce themselves.
So hi, I'm Giles Berrisford. I'm a consultant psychiatrist working at the Birmingham Mother and Baby Unit. I'm also the chair of Action on Postpartum Psychosis.
Hi, so my name's Ian Jones. I'm another perinatal psychiatrist, but also the day job is as a researcher. I'm a professor of psychiatry at Cardiff University, and I'm a trustee of Action on Postpartum Psychosis.
So yeah, just to say just a little bit about APP. We're a collaboration between families who've experienced PP. So that's like myself. I had postpartum psychosis 6 years ago, and I'm going to talk about my story a bit and share my experience of PP. So I'm the peer support coordinator at the charity, and as we said, Giles is a clinician and Ian is an academic. So yeah, it really is a collaboration between families with lived experience and clinicians and academics. So this Facebook Live is a really good example of that, I think, of what we do as APP. So I am going to start just by sharing a bit of my story with you. So I had PP 6 years ago, and I had no previous mental health history. And when my son was 3 days old, so I had a very normal pregnancy as well. No symptoms at all, really happy pregnancy, normal pregnancy, and a normal birth, a planned home birth. And then when my son was 3 days old, after he was born actually, for those first 3 days, I was feeling very elated, really happy. I wouldn't have said I was struggling in any way. And I didn't sleep at all, which is a very common symptom of PP. And it wasn't actually that I struggled to sleep, it was more that I just didn't feel I needed to and didn't want to. It wasn't like, oh, I really need to sleep and I can't sleep. And then when my son was 3 days old, it was the night time, and I went to bed to try and get some sleep. And then all I can say, it was like my mind snapped. So it was very sudden and very quick, very acute. And it was the feeling of when you're waking up from a nightmare or a dream and you're kind of not sure for just those first few moments what is real, whether you're in the dream and what's reality. So it was like that, but it kind of kept going and going. And then I thought that I'd killed my son in bed, that he was dead. And then it kind of escalated from there. So when my partner came up to give me my son to breastfeed, I just remember being very confused and just saying, is this real? Is this real? And then basically he tried to get me to go to sleep and I couldn't sleep. And then eventually he went downstairs and phoned the labour ward because he gave me my son to breastfeed and I just didn't know what to do. And I was saying, show me what to do. I don't know what to do. Is this real? So I remember it all. I had that kind of lucidity, which is strange, but I just completely confused. And then I went to A&E and it escalated from there. I was 24 hours in A&E, amazing support from the head midwife there. But I had started having lots of really scary delusions. So some of the delusions in my psychosis were that I thought I was the devil, I thought it was the end of the world, I thought I killed my son, like I said, and I thought I had to choose which members of my family I could save, and I could only save 3 people. So I think the big thing I would say about experiencing postpartum psychosis is it's so scary and it's a hugely traumatic experience. You go through this huge trauma because obviously all those delusions you believe and you think they're real. And I was very lucky in the support I got. I've heard now obviously a lot of stories from different women who've experienced PP and the kind of different support people have managed to access. But I did go to a mother and baby unit within 24 hours. And it took me about a week, 2 weeks for the psychosis to go and to be more stable. And then I was there for about 6 weeks and recovered very, very well. And it was amazing to be with my son in the mother and baby unit. So I was never, ever kind of separated from him. Obviously, when I was very ill, I couldn't be with him. But I remember even in a lucid moment in the middle of, psychosis, kind of going in to see my son when he was sleeping in the nursery. And so just keeping that bond, even in the middle of being very, very unwell. But then after 6 weeks, I hadn't had any home visits, and I was due to go for my first home visit. And over that week leading up to that, I became very anxious about going home. So I wasn't doing all the night feeds in the mother and baby unit. I was doing everything else for my son, but not the night feeds. And I just became very anxious about that if I went home and had to do all the night feeds, I would be ill again, basically, and would become psychotic. And then that kind of built up into maybe a slightly more psychotic symptoms again, so kind of paranoia. And then I basically took to my bed and couldn't get up, and I had really kind of scary thoughts again, kind of almost psychotic, paranoid thoughts. And I basically went into a very deep depression, which a lot of people who experience PP also experience. And that, I think that's for me, that was a kind of double whammy. I came out of that depression finally getting out of bed and felt completely numb, completely broken, and just not myself, like kind of no feeling at all. And yeah, for me, I think that was the hardest thing. It was kind of like I said, a double whammy. And I remember just saying, what's this now? What's happened to me now? And then they said, yeah, you've got depression. And it was the kind of depression that took a long time to get over. So I was then in the mother and baby for maybe even another couple of months. And yeah, kind of slowly had visits home and then went back home. And I think with the depression, I was kind of I was given an antidepressant, and that kind of took away some of the numb feelings, but then you're kind of left with low self-esteem. I thought I was an awful mother. I thought that I wasn't interacting enough with my baby and that I was harming him. And kind of back home every day, kind of on my own with my baby, and my partner would obviously help and worked part-time, so he was around quite a lot. But I just felt so alone and isolated. And, I had lots of mum friends from a mum group who had babies all at the same time, and they were lovely and supportive. I didn't feel like they were judging me, but when I went to see them, they were all breastfeeding, for example. I decided I kind of couldn't breastfeed, and then kind of didn't want to restart it. It was just focused on getting well. And it was, I suppose, that feeling of they were in another completely other world to me, and I every day, most days, were kind of just a struggle to get through the day and to get out to things as well. Felt like a big task to do. And I think with the depression, it was up and down. So I'd have a good few weeks, and then I'd dip again. Something would maybe make me anxious. There would be some reason I would dip again. And then I want to talk really a little bit about what helped me to recover. Really, what were the things that I feel helped me to get through PP and the depression. And the first person would be my son, my lovely boy, because he was the reason I would get up every morning in the mother and baby unit, force myself, especially in the depression, force myself to be with him. And I did always feel actually some kind of bond with him. I felt in the numbness of the depression, that was difficult to feel, but he was the reason I'd kind of get out of bed and be with him. And then I think as he kind of got a bit older, about a year and a half, it was kind of very clear actually that he wasn't harmed by what happened at all. He was actually very confident, happy boy, and that very affectionate towards me, bit of a mummy's boy actually, and that our bond was kind of fine. And I think babies don't give that much back, and that's difficult, I think, when you're feeling insecure. And yeah, so my son, and then obviously family and friends, my partner kind of stuck with me through it all. We were kind of in it together. He had his own trauma of kind of experiencing really horrific, watching me in a psychotic episode, he's got his own story, of kind of the trauma of PP. And yeah, the right professional support, basically. I can't say, I've said a bit about the importance of the mother and baby unit, but I really can't emphasise that enough, how important that was. Because you can imagine if you have a delusion that you've killed your baby, or maybe that you never even had a baby, to be separated and, not with your baby, it will just compound it. And that whole, bonding problem you have because you've been so ill to not, be with your baby. And when I remember in the depression, at times I couldn't even hold him because it just felt so overwhelming. But I could sit next to a staff member who was holding him, and that felt safe, but I could still be with him. So it was so essential. And then afterwards, at home, I got support from the early intervention psychosis team, and because there was no perinatal mental health team, but at least they were specialised in psychosis. So I did get good support from them, and I got good I got therapy, CBT, which was really essential for helping with the depression and the kind of negative thoughts of the depression, and to have positive phrases I could tell myself. And I think as well, kind of just empathic professional support. I think if there are any professionals watching this, you can make such a huge difference to people by just being empathic and seeing patients as kind of individuals and not just the patient. And I have heard, I'm quite lucky I didn't experience any kind of maybe bad care or whatever, but I've heard stories of kind of women that have experienced, witnessed, people being kind of not treated that well, and that's kind of added to the trauma. It's already traumatic going through a psychotic episode, and then if you add not receiving the good professional support. And then lastly, and not least important at all, after about a year of after the psychotic episode, I kind of dared to Google postpartum psychosis. I kind of couldn't even think about it. I just was focused on trying to get well. And I found APP, Action on Postpartum Psychosis, and I found the online forum, and I can't tell you the relief I felt when I just kind of read these stories, and I thought, this is normal for PP. What I experience, my feelings are normal. There's other people, and it's a thing, and there's a whole community of mums here who've gone through this. And at that point, I'd gone back to work. I was kind of functioning, but you're left with kind of loss and memories, trauma, and a kind of a lot of questions, and that kind of carries on, I think, over when years pass, like thinking about to have other children, deciding not to have other children, and then kind of the sadness with that. So that peer support for me was absolutely essential to I have no doubt that I wouldn't be as recovered sitting here now able to talk about my experience. And also I think being able to support people on the forum, support other mums, has kind of transformed the experience really into something positive for me. And I know a lot of our amazing volunteers say the same thing. So I think those are the things I'd like to say from my personal story. I think now we thought it would be good just to talk about kind of what is PP. So I'm going to kind of ask Ian, as someone who's kind of a specialist in postpartum psychosis, kind of what do we mean when we use the term postpartum psychosis?
It's a really good question, and I think when we talk about postpartum psychosis, what we're talking about is women that have a very severe episode that comes on, has its onset in that immediate period after women have a baby. We know that childbirth is a very strong trigger for episodes of psychiatric illness, that women are more likely to become severely ill at that time than any other time in their life. So we're talking about illnesses that affects probably around 1 in 500, 1 in 1,000 women. So it's not something that's very common, but we're talking about something that is very severe. We're talking about illnesses that can have symptoms that are mood symptoms. So mood can be high, elated, or irritable, or mood can be low, and often in PP those moods are very mixed up so that they're very changeable. And as the name would suggest, we're talking about an illness where psychotic symptoms can be present. So by that we mean delusions, believing things that aren't true, or hallucinations, hearing voices or seeing things that aren't there. So that's, I don't know if that answers your question, Ellie. That's what we talk about. The good news is that although these episodes commonly occur very quickly after having a baby, in that, coming on in that first postpartum week is very typical that you experience. We're talking about episodes of illness that have, often have a good outcome that might take many weeks or even months. And actually that experience that you had as well of after that initial post-psychotic period, having a longer lasting depressive phase is common, but women really do get better and recover, and there's a very positive message that it's important to make. I think that as you illustrate, you can get better from this, and you go on and enjoy your baby and have a fantastic life.
I think it's really interesting when you say it's not common. We think that 1 in 500. So just in Birmingham, that means that 40 women every year are going to get postpartum psychosis. And then if you think about the whole country, that's probably about 1,400 women every year will get postpartum psychosis. And as you described, it's really severe, really traumatic, and yet not many women and not many families actually even know it exists until it suddenly happens and comes out.
Did you, on that point, Ellie, were you aware of postpartum psychosis before you had the baby?
No, and most mums I've talked to never heard of it. So there was probably something, I was given like this green NHS book, and there's probably one line in there, but it wasn't emphasised at any antenatal class. I think that's something that as APP we really feel people should be told about the early symptoms, what to spot. Because we were like, what is this? What's going on? Whereas I think if like my partner had known, he would have been like, okay, I think she's experiencing this. I think that's really important. And to get help quick is really essential, isn't it?
Did it take your partner and you time to realise that there was something not right here then? Do you think you could have identified it quicker and got help quicker?
It could have been maybe a bit earlier. But to be honest, it came so suddenly and so quickly. Like I'd had maybe a few symptoms the day before, probably, looking back. But it wasn't so acute as, and so sudden as, that episode,
and I think that's really common as well in my experience. So when we admit women into the mother and baby unit, often families, the mom, have never heard of postpartum psychosis. And all they know is that it's extraordinarily unwell, and yet where does this come from and what is it? It's utterly terrifying.
And I think it's not just the message that, knowing what to look for and knowing that if your partner shows some of these symptoms, then it's really important to get help. I think the other important message is that this is something that people get better from as well, because actually for women going through it and for their partners or the rest of family members looking at them, sometimes they can feel, because you hadn't had any illness before. This
is the first,
and probably around 50% of cases that's the situation, that this is the first episode. So and actually, unlike many other kind of psychotic illnesses that can take many weeks, months even, or years to kind of come on very slowly, one of the characteristic features of postpartum psychosis, it comes on so quickly, and women can go from being very well to being as ill as we see people in mental health services, within hours. So have that message of hope. I think that this is something that women get better from. It's really important to get over.
Definitely. That's kind of the main message I give everyone, and I really believe it because I'm well and I recovered, so we can be evidence of that. And you've talked a bit like what are the symptoms of PP, and I think I've heard you talk before in like saying it's can be kaleidoscopic. Like,
yeah,
I think
that's a really phrase that was used in the kind of early descriptions of PP that I think really does give you a good picture of what this illness can be like.
Yeah.
You can remember when you're a kid looking through a kaleidoscope and turning a kaleidoscope, the patterns continuously changing. Well, for often, and I think that's an important point to make, is there's lots of variation here, and everybody's experience is different.
Yeah.
But often in PP, what you see is that pattern of symptoms, those delusional beliefs that women have, change very rapidly, and the mood can change very quickly. So that constantly changing pattern, I think, is something that. The other thing that's said to be a very typical symptom is that kind of confusion, complexity of not knowing what's happening. It's very difficult to describe, but from what you were saying, it sounds like
I kind of knew,
that.
especially at the beginning of the episode, I knew what, I have very clear memories of my partner standing there, what happened, what was said, but just feeling really confused and really scared. That was my overwhelming
feeling. Sometimes people say it's like being in a waking dream.
Yeah,
or something.
definitely. That would be my waking dream, my experience. And we talked about kind of PP, occurring in 50% of cases where women don't have a previous history. But are there groups of women that are more at risk?
Yeah, certainly people who've a history of severe mental illness in the past. And particularly actually, there's a relationship with bipolar disorder. So women who've had a episode of illness that's had a bipolar label, particularly kind of more severe forms of bipolar. What mental health services sometimes label as bipolar 1 disorder, then the risk is quite high. So in the work that we've done, the research that we've done with the help of APP, probably around for women who have a diagnosis of bipolar disorder, for women with bipolar 1, following each pregnancy they have, there's probably around a 20% chance of them having an episode of PP, and then probably another further 20 to 30% chance of a depressive episode, a non-psychotic depression. So it may be around 40 to 50% chance of an episode of illness. So for women who've experienced those kind of illnesses in the past, it's really important that that services discuss that issue with them and talk about the risk. Not that they. I'm a very strong believer that nobody should be telling anybody that they shouldn't get pregnant or they shouldn't start a family, but people need to, women need to know and go into make decisions about pregnancy, knowing that risk and how to get help. And probably Giles is that person to talk about the kind of ways that they need to should be helped. But it's something I think is really important that we consider. All women that we look after in mental health services in their reproductive years, as it said, those years when they can have a baby, we really talk about their thoughts about having a family and really make that a really core part of what mental health services do.
So I think bipolar, I think, is used a lot as a term. I suppose it's just. So when we're talking about, we're talking specifically about those women who get really severely depressed and also get really manic, they get really high, psychotic, and get really ill. And I suppose it's that group that we specifically want to recognise. And probably any woman who's really had major mental illness, I think it's just recognising it's a really vulnerable time. And actually it's really okay. So tell your midwife, let people know beforehand so that we can actually support you during the pregnancy, and postpartum it is really important. And even if you're worried, say before you get pregnant, then actually having some preconception advice. So asking your GP to refer you to see a perinatal psychiatrist and getting that advice before you get pregnant is actually really sensible. It just helps you to make sure that you're on the right medication and also making sure that you've got the right support and the right help as and when you need it.
And what would you kind of advise women? Because there are things, isn't there, you can do to kind of prevent episodes getting ill.
Definitely. So I think medication is really difficult, isn't it? But actually it's really important. But I think it's a really emotive topic. So when you're pregnant, the thought of doing anything when you're pregnant, so the thought of eating certain foods or doing certain activities, that you think, well, no, I can't because I'm pregnant. And so the thought of actually us giving fairly major psychotropic medication feels like
really difficult.
That's difficult. So I think it is actually talking to the psychiatrist and actually just making sure that you've had an informed discussion. Because
it's about people having information, isn't it? And then you can make a decision. You're not going to say, oh, you must take this medication. Like, you won't say that, but it's more just saying, oh, this might prevent. I don't know what you would say. Everyone can make individual
Charles would agree that there's no right or wrong answers often. And I think it's really important that that individual woman's situation, her individual history, the evidence for her that medication has been effective or not, that's what's important,
just making sure she's got, it's giving her all the information.
And making her and her partner able to make decisions that's right for them, that they can be comfortable with.
And not doing things suddenly. And so just suddenly stopping medication can be problematic. So it's actually just doing it in a controlled way and with support from someone, from your healthcare professionals.
And a specialist, perinatal psychiatrist.
And that's the good news actually, is that, that there are more services being developed all the time, so that is the direction of travel. We're still not there yet. But we're certainly in the UK, we're going in the right direction, so that all women who need to have that specialist advice hopefully will be able to get that. Actually, just on that one thing you asked me who, particularly at any groups. Actually, one thing we do know is that you've had an episode of PP before. That's puts you in. So it's even if it's some time ago, even if you're currently very well, even if your situation has changed, because often you see people say, well, actually, I was in a really bad place when I had the episode, but I'm with a new partner now, and it's fantastic now, and very well. It's really important to recognise that does increase the risk, and actually to share that, talk to the people looking after you in your pregnancy, and hopefully get referred to a perinatal psychiatrist, ideally to the perinatal mental health team to help you through that the pregnancy and postpartum period.
I did just want to say on this topic, we do have APP has a guide for planning pregnancy for people who are at risk of PP. So it was written by families who have experienced PP, mums who experience PP, and clinicians. Ian, I imagine you're involved in it, and Giles. And that's got all this information in it. So if you are thinking of having another child, you've had PP, or you've experienced bipolar or mental illness, then this guide is really good. I'd really recommend it. And just to ask really, what do we know what causes PP? So there's these 50% of people know previous history, comes out of the blue. Why did I get PP? And tell me.
I wish I knew, Ellie. It's a fantastic question, really important question. It's a question that motivates the research that I'm involved with, and what's fantastic about that collaboration between people with lived experience, the clinicians and academics at APP is the help that APP has given in informing women about the opportunities to participate in research. So I might come on to say something about that, but in a while. But I think becoming a mother, particularly becoming a mother for the first time, is massive change. It's a massive change socially. It's a massive life change. That's undoubtedly important for many people with, when you women that have mood episodes in the perinatal period, that, those psychological, social factors are important. What seems to be the evidence with PP, though, is that, not to say that those are unimportant, but biological factors may be have a bigger role. So we know that genetic factors can be important. From work that APP has helped our research group with. We know that the biological disruption of sleep, the circadian rhythm disruption could be very important. We know that there are potentially other factors that may be involved as well. Like immunological changes that happen in pregnancy, that we're understanding more about their impact on the brain all the time. So the big hormonal changes that occur at that time, with the hormone levels massively increased in pregnancy and drop at exactly that time when this illness comes on. What I'd be what I think we should guard against is any simplistic idea that it's just one of those things. It's likely to be a complex interaction of the biological, the psychological, and the social. And certainly, my feelings that we need to understand this on all levels. But but we're trying to do work to understand what are those factors that are involved. With the hope, and why we're doing the work is the hope then that we can understand better, to predict better who's at risk, which is really important.
And then you can support them better, maybe prevent an episode.
And then intervene in some ways. If we understand, I'm a really strong believer is the more we understand about the causes of these conditions, the better we can make it for women and their families who suffer in the future. So it's a fantastic question. Wish I knew. There's some really important clues that we've got. I'm sure that the hormonal changes are involved. We know that genetic factors are involved. I think it's not simplistically going to be those. It's going to be those complexly interacting with all the social and psychological factors. Yeah.
And I think some people are just kind of more affected by lack of sleep than other people, for example. Yeah. I think we're going to go on now to kind of treatment of PP. And I did want to say actually that probably a lot of you are commenting, and I hope we'll have some time towards the end to kind of look at the comments and maybe answer some questions. But yeah, just to talk a bit now about kind of what's the treatment for PP. So Giles, maybe, because Giles is the lead clinician in Mother and Baby Unit in Birmingham. So kind of what would you usually do to treat someone who had PP? Is it all medication or is it talking therapy as well?
So I think it's going to be a combination of factors again. So I think, as you both already alluded to, so sleep is really important. And often when moms, they're just getting no sleep at all and just are unable to sleep. And it's very difficult to know what comes first. Is it that they just couldn't sleep that causes PP, or is the PP presenting itself because they're just unable to sleep? So often we'll try and give medications, try and help people to get some sleep really, and just try and take the edge off things so they're getting some rest. And often moms, when they come in, they're really quite agitated and quite distressed by the situation. They can be. And so again, medication can help just to calm things down and just make things feel better. But I think it's very difficult for you. You can't just say, right, here's a tablet, take it. It's going to have to be about relationships, really. And I think that's why Mother and Baby Units are such important and special places, because having a Mother and Baby Unit, we're dedicated to looking after moms and babies. We recognise that this is a really special time in the life of that family. And therefore, we've got lots of really great clinicians who work in Mother and Baby Units who are just really skilled at getting moms on side and making this, what is it, a really traumatic and scary experience, hopefully feels like less traumatic and less scary. And actually just explaining things can be really helpful, and actually just helping moms to come to know, actually this is going to be helpful and trust us and try and do that is really important. And so I think it's a combination fact. I have no doubt that medication is probably the mainstay of treatment for most moms who get PP. It is. So we definitely have to go down that route. But
and it would be an antipsychotic, obviously.
So normally we think of it as almost a mood disorder, and so something which stabilises the mood is useful. And so often we'll use an antipsychotic to try and do that, to stabilise the mood and keep things in the middle. And I think again we just don't know enough about it. So it's very difficult to say this drug will definitely work. And so it's just sometimes it is a bit of trial and error and trying to make sure that we get the right single drug or even a combination of drugs that works. But invariably we get there. So moms do get better. It's just a case of trying to find the right medication which moms find acceptable and works for them. That's the key.
And if people go into like the depression, like I did, like what would you give? Like I know obviously what I had an antidepressant as well. Like how would you balance that? Because I imagine that must be tricky to balance like kind of psychotic, high mood, or whatever, and depression. I don't know. I'm not clinician.
No. I think it's spot on. Actually, you are totally right. So I think it's really difficult, because what we don't want is a mom who's just been really high, who's been elated in mood, and now is really low. So if I give you an antidepressant, the point of that is to make you a bit higher. And so my worry is that, what if we then make you high? And then you can actually get on this cycle, if you like, of just ups and downs. And so the first mainstay really is thinking about how do we make sure we've got enough of a mood stabiliser on board to make sure that if we do add an antidepressant, we've got something else to make sure that we don't make you even more unwell again. Because what we don't want is for this just to be a roller coaster. We actually want things to be in the middle. And so mood stabiliser probably is an antipsychotic. maybe another drug, so things like lithium that sometimes used, and really good, just trying to keep things in the middle. And then if not, then think about an antidepressant, so things like fluoxetine or an SSRI, something like that is another good drug.
Yeah, I was on olanzapine and then escitalopram as well.
Yeah. So
I think I came off.
Antipsychotic one.
And I came off the antipsychotic after I think 12 months.
Yeah.
And then the antidepressant a little bit longer after that.
And sometimes the antipsychotic, they have side effects, so they can make you feel really tired.
Yeah.
And then of course it's really difficult to know. So if your mood's dropping, that makes you feel really tired and lethargic as well. So it's difficult to know, well, is it the side effects of the medication, or is your mood starting to go down? So sometimes things aren't that clear. So we need to look at other factors which would give us clues, I guess. So whether or not you're getting any sleep, whether or not how you feel yourself generally, whether or not you've got energy or interest in doing things and stuff like that.
And it's really important, isn't it, particularly with antipsychotic, to come off gradually. Is that right? Yeah, because
pretty much with all.
You can kind of relapse, if you don't come off.
Yeah. Just I completely agree with what Giles has said. I'll always completely agree with what Giles says about anything. It's my default position. But I just think one thing APP's really helped us understand, actually, by work that they've done with the women that are part of APP, is while Giles is completely right, that initial phase, medication is the mainstay.
Yeah.
I was interested in what you talked about and the guilt that you felt and the coming to terms with what had happened. I do think we need to be better at knowing how to help women, in that recovery phase.
Definitely.
And that what help, what treatment, what talking treatment might help them, come to terms with what's happened to them in some respects. I think APP has been fantastic in helping us understand that, even for something like PP, postpartum psychosis, that is really, medication is the mainstay in that acute phase. There are other ways in which we need to help women.
And that's definitely why Mother and Baby is such a great place, is because we can manage that immediate chaos, if you like, that traumatic event. But then we can also support with the adjustment bits. Because you start to recover. It's such a shock, actually, isn't it? This has happened at such an important time. And then it's a case of just trying to work out, well, how do we support you in becoming mom again? And think about that relationship with your son and moving forward. So I think it is having psychology on board to make sure that they can help with that.
And perinatal teams have, a lot of perinatal teams in the community have that as well, don't they? When you're back home. Because there's so many mums, I've spoken to, you don't get any therapy, nothing, and you've been through this huge trauma, and even afterwards, I think even a year after, to be able to talk through, it's kind of should be routinely offered.
Really, when you really need.
Kind of CBT is a bit different, isn't it? Because it's more, how to cope day to day and practical advice most thought patterns, but
We do need a combination, so I think the Mother and Babies, they've got psychologists. Absolutely, they've got psychologists, they've got occupational therapists. So just think about the day-to-day functions that you need to fulfil in order to be a mom. So there's a whole new range of tasks which you have to learn, aren't there? And then you've just been ill and trying to adapt to these new tasks is actually really difficult. So OTs are really good for that. They've all got nurses there who can make sure that we.
I've got so much good advice from the nursery nurses.
So the whole range, isn't it? So it's lots of professionals have to be involved.
Actually, the other thing that I meant to say, because I think picking up on the experience that you told us about, Ellie, was sometimes the symptoms of PP, the psychotic symptoms, the mood symptoms are the most obvious, but actually I think it's very common for anxiety to be a really big issue. It's probably something that's under-recognised, and
definitely.
So I was really interested that you said for you that was
that triggered the depression, definitely. And I think that everybody I've talked to has that fear of becoming unwell again. And I'll be honest, even now, if I'm feeling a little bit stressed or whatever, I start thinking, oh God, like I could become unwell again. And, I've never got, I'm very well, but, there's always in the back of your mind in a way. And I don't want to kind of make people think, oh no, I'm never going to recover. But I don't mean in a negative way. It's just, I think there is always that fear. You always hold that fear that
and I think that's something that
become unwell again.
Teams need to talk through with women who've been through PP, that there's definitely, and we've talked about having had one episode of postpartum psychosis, further pregnancies are definitely periods of risk, and you need to take them. But actually, for some women with PP, they just have episodes after childbirth, and that's it. But at least 50% of women will go on to have other episodes, not just after further pregnancies, but at other times. And actually, I think it's really, I don't know what Giles thinks, but I think it's quite important to discuss that with women as well. So, because actually something else that's come through the work that APP's done that's helped me understood that is that a number of women said that they were just told about the risk if they had another baby and made a child, the decision not, but then became ill, not related to childbirth later, and they, so I think, it's really important to discuss that.
Yeah. And I think it's, there's a positive to it as well that, you can then, for me, I prioritise self-care, and in a way I didn't before, I was very just busy and kind of looking after other people quite a lot, and, I've really prioritise self-care. That can be a good thing.
Yeah, and I think the more information that moms and families have got, the better. Then they can make informed choices, can't they?
I would rather know that.
And that is, again, big enough APP, a lot of it, but I guess that's because it does such fantastic work. That information that APP has on its website and its guide,
you can go on to that.
Is great. It's fantastic.
So I kind of mentioned the pregnancy guides. We have a lot of information on our website. If you just Google action on postpartum psychosis, you'll find us. But we have a guide for partners. I know the dads in mine did a live just before us.
Dad's Day today, isn't it?
It's Dad's Day today. And Dad's kind of co-wrote, this is a real co-production, I think there's over 100 dads filled in questionnaires or whatever in this guide.
We probably should say partners, not just
partners. It is partners, so it's partners. And it's quite useful actually even for grandmothers or whatever, anyone supporting anyone who's had PP. And then we have a recovery guide, for women who've experienced PP, and that's helpful for anyone supporting them to read as well. And then the planning pregnancy, and then we obviously have our peer support network, which we have an online forum, and so that's for anyone who's experienced PP basically, and also family members who need support. And then we offer one-to-one private message email support. We have a fantastic group of trained peer supporters, volunteer peer supporters, who are on the forum and offer online peer support. We're trialling face-to-face support as well. So there's some kind of more social groups. So it's not kind of formal support groups. It's more just trying to be really a network of mums who've experienced PP who can just share experience and support each other. We're hoping to kind of offer more phone and Skype support, but we do offer some now. So, if you really would like to talk to someone who's had PP, you might get me, probably, most likely. But, I think
that's the thing, isn't it? So although it's going to affect 1,400 women every year, I think they're all over the country.
So
they're all spread out.
Definitely,
And I think
I hadn't met anyone who had PP before I found APP. It's really hard to find people, just generally, without going through APP.
That must have been really lonely.
Very isolating. Really, You think you're really weird and different, like what happened to me, and nobody else has experienced it.
So I think it's not just moms and dads who don't have heard of it. Some healthcare professionals might have heard of it either. So trying to get them to understand what we had is very difficult.
And Ian, do you want to talk just a little bit more about the research? Because that's another thing we do, which is important. What research are you doing at the moment? If there is anyone out there watching who has PP or is bipolar?
So there's a couple of active pieces of research that APP is really helping us with, which has been a fantastically productive relationship. The first is we'd really like to hear from women who've experienced PP, and that would be fantastic. And for a member of our team to go and visit them often, or do an interview over the phone and get some information about their experiences. We ask for a blood sample so we can look for those genes that may nudge up or nudge down risk. So that's the first thing that would be great. And then the second study that we have at the moment that's been really important, I think, is for women at increased risk because of a history of bipolar disorder, or they've had a previous postpartum psychosis who are pregnant, we really want to understand as much as we can about how to individualize that risk for that individual woman. The best way to do that is to do kind of a study that follows them through pregnancy into the postpartum, gets lots of information. And again, so hearing from women who are pregnant, who have a history of bipolar disorder or postpartum psychosis would be fantastic. So as far as letting us know, going on to the APP site would be one way, and contacting us through that way. But the other two websites that would be interesting to look at anyway are National Centre for Mental Health, ncmh.info is the website, or the Bipolar Disorder Research Network, bdrn.org. So ncmh.info, bdrn.org, and there's a button you can click on both those sites to volunteer for research, and really are fantastically grateful for any help that we get. That collaboration to really take things forward, to understand better the causes of this illness, and hopefully that in the not too distant future we'll be able to. Giles talked about some of the limitations with the ways that we have of treating this illness at the moment, but the only way that we're going to improve that is to do the research and understand better. So thank you for asking that.
Oh, no, that's good. I'm just looking to see if there's any questions on here. It's so nice to see lots of you watching and commenting. Lots of comments about kind of the fear of becoming ill again. I really relate to that. Okay, a question which I think is interesting one about people who've had an episode maybe when they stopped breastfeeding, so later, and Ian, maybe you might be best to know about that. Is there an increased risk then? What do we know?
It's probably that the perinatal period is a series of different risk periods. That for some women, late pregnancy and pregnancy itself might be a risk. For some women, it's childbirth, and that's the event that we know really has an increased risk. But for some women, definitely. It's that some of those things that happen later in the perinatal period. For some women, it seems to be getting their periods back. That can be a trigger for some people. Stopping breastfeeding, or that can be. Probably they're not as obvious and not as strong triggers as childbirth itself. But certainly, the women that we've seen in the research and Giles clinically back this up, that can be the
definitely. So we see all that, and the other area that we've been looking into it is things about menopausal stuff as well, isn't it? So that's an area that these more research is
definitely, and we've definitely had some women who've and this is why getting the individual stories of women is really important for research. Some women who've been who've had a further episode of illness around the time that menopause is starting. Probably again not as powerful a trigger as childbirth itself, and the hormonal changes that, for example, that happen around menopause happen over many months or even years. But being aware of these periods is probably a good thing, I think.
Yeah, and it's certainly an area where with more research, with more information we can get to us, so when they're discharged from the mother and baby, we're able now to get more and more information and say these are things to be mindful of.
Yeah, and it's really difficult balance. I'm just kind of reading a few comments while you were talking. Kind of a lot of people saying the fear of becoming unwell is quite high, and so it's getting that balance, isn't it, of knowing that information, but then also not kind of try not to focus on it too much. Like for myself, I wouldn't want to spend my whole menopause worrying I might have a relapse or something.
And I think getting
really
those I think being aware of it's like going into another pregnancy, being aware that you're but knowing that actually the likelihood is that you probably will remain well, and getting those risks into perspective is really important. And knowing that that everybody who's looking after you is aware of that, and you've got a plan, and often in the second pregnancy, you know what you're looking for, and you can identify becoming ill quicker, and actually get treatment quicker.
So it's never exactly the same the second time around. And also because you've got more information, you can put a really comprehensive plan in place. And often with these comprehensive plans, it's quite detailed, so you can say exactly what would you like us to do, when would you like us to do it. And our real hope is that we don't need to use any of it, because you just say, well, and that's perfect, isn't it? But
and there's really
got
a lot
over
of positive stories on APP forum of second pregnancies, and and some people do come on well again, sadly, of course, but I think they recover as well.
And just having that control of them down.
And can take
and just like visiting the mother and baby and seeing where and making decisions about where would you want to go? You need to be admitted. Would you want to go here? Would you want to go somewhere else? What would you want to have?
There is one question that could we just look at time? We've got 10 minutes still. Would Ian consider ECT as a first line of treatment? That's kind of both of you, really. Like, what would you think about ECT?
So it's a first line. So yes, we do use ECT, so electric shock treatment, which sometimes can sound quite extreme. But in actual fact, we do use it. It's really successful and it's really helpful for lots of mums. And I suppose if I was using it first line, it's probably because we think actually this is life-threatening, and sometimes it can be. And so for some of our mums, they're so unwell that they literally can't do anything.
So they're not eating, or
So they're not eating.
Catatonic, maybe.
So it just stops. Sometimes mums are just literally just stopped. They can't eat, they can't drink, they're not interacting with us at all. And so we don't have time for medication to work. And so as you said, it takes a good couple of weeks for things to start to get better. We don't have that time to wait. And so in those situations, then I would think about electric shock treatment. And I think it's just recognising that that's necessary. And I think it's also about recognising that the benefits of that treatment outweigh the risk of waiting or stopping. We just have to make a real careful consideration, and doing that with the family. So often the mom isn't able to interact with that. And so it's making sure the family are on board and they understand exactly what we're doing and why we're doing that.
I mean, I have heard from a lot of mums who say ECT saved my life, mostly. And it's kind of got a bit of a scary reputation, hasn't it? Quite negative reputation, but I think in certain cases it's really essential, isn't it? Like you say, it can be life-saving.
And it's just a medical treatment. And I think the way it's sort of perceived...
And it's got better the way it's done now, isn't it? It's,
So it's like, so you have an anesthetic for sleep, you don't actually notice anything, really. It's just an intervention to makes the brain start working again. Kicks up the brain, I like that. I see that,
I think the way it's been portrayed in the media and in certain films has been very negative, actually. But I think, the experience many that you've had through talking to women is it can be really beneficial. And I think there is some evidence that actually the episodes that occur in the perinatal period particularly respond well to ECT. So it probably should be something that we don't just reserve for the, it should be something we should think of. Because I think for me, there's really good reasons to get women as well as quickly as possible. Because actually, one of the things that many women tell me, is that period where they maybe can't remember, and they're ill, and that's what they regret. So I think the fact that there's a baby means that getting women well quickly is really positive thing to do. So.
And so even if we don't use it first line, I'd definitely be using it sort of second or third, because
if someone maybe goes into a depression
or just isn't responding to the medication,
or isn't responding to
then ECT
it's still psychotic after
really
trying different medication. I'm just having a look, see if there's any more. Lot of comments about mother and baby units, and there's 4 new units now, is that right? So that is improving in the UK.
We're hoping
really
that there'll be 5 if the Welsh Government keep their promise, and we get really Wales. That would be
it's
great.
Really desperate in Wales. We really need and the importance of therapy. A lot of people saying and kind of not being able to access therapy. We need a mother and baby unit in Wales. Yes, why is treatment so varied depending on location? I think, I think we're hopefully trying to improve that, aren't we?
So I think things are getting better.
Definitely.
I think that is something to celebrate, actually, and to be positive. And many APP has been involved with the Maternal Mental Health Alliance over the last few years to campaign. I think when APP, was at the first meeting of what became the Maternal Mental Health Alliance, we wouldn't have believed for a minute how, that we could have, done a small part, and it's building on lots of other efforts that people have done for many years. But the progress, I think, over the last 5 years has been incredible. Giles is involved with another hat that we can't talk about. But in those changes, but I think it's really something to celebrate. Clearly, we're not there yet. Clearly, there's more to do. Clearly, actually, the other thing is that perinatal mental health services don't operate in isolation of the rest of the health service, and I think actually, there are issues in the health service much more generally, aren't there? But I think, those developments, those new teams of specialist services that are coming online, those new mother and baby units, this is really positive, good news to celebrate. The Maternal Mental Health Alliance, I'm sure, will still campaign to for those things to be improved, but I think it's something that we should feel positive about.
Definitely.
I think it's something APP should feel proud about being involved in, being part of that.
And also, kind of a bit related to that, I think the awareness of postpartum psychosis is so much more, like, since APP, but I think pre-APP, like we said, there was no way to find any other women who had PP, and also I think the media have got a lot more informed. I think people are more informed. There's a lot of misinformation and very kind of scary misinformation about what PP was, and a lot of stigma, and I think that there is obviously still, but I still think it's got so much better than.
I was just going to say, think about the work APP and Ian did with EastEnders and the
definitely.
I
think it was really useful, and sort of just making people aware of what it was and
I've got to mention Claire Dolman's input in that as well. It's a key person, and I think whatever we feel about how to get a big soap that reach over 10 million people per episode to cover a postpartum psychosis as a storyline. And do it in a reasonably responsible way. Actually, I thought it really does help in that. I think another good thing that APP's been involved in.
I think that's all we've got time for. It's kind of 5 to 7. It went quick.
Which is amazing, actually, because we thought we'd be running out of things to say after 20 minutes.
So I think maybe just one very last question about kind of what support should be available when people are discharged from NBU. And I mean, I would say ideally, isn't it, to be supported by a specialist perinatal mental health team, and there's going to be more specialist teams throughout the country. I know that's the postcode lottery a bit at the moment, but hopefully things are going to be getting better and better.
So we'll get services for people to link into. I think that's really important. But also, I think APP is actually really important. So I think if you have something like postpartum psychosis, you do actually need that specialist input. And I think often when I'm discharging moms from the mother and baby, I'm always telling them about APP. I'm telling them about how useful it is just to read other people's stories, and even if it's not for the mom, for the family to see that this is something that happens. But also, we know it could be a year later before they actually say, I just need to know more about it or talk to somebody about it. And so I think it's just think about the whole process, isn't it? And I think that's why APP is really important. So I think there are definitely NHS organisations which we need more of, but I think also, and there will be more of, but I think also we need to think about the charity organisations like APP, which is I think fantastic. I know, Jeff, it's fantastic.
I hope we haven't gone on too much about APP, but it's really weird. There's a lot. I think I just feel so passionate that we have so much resources and information, and support.
Absolutely.
So, and I just want everyone who's experienced PP to know what we have and what's there. I think we need to finish now.
I just want to thank you for telling your story. I think it's so important.
Thank you, and thank you to Perinatal Mental Health Partnership for letting us do this Facebook Live. Thank you, everyone, and thank you so much for watching.
Thank you. Bye.